Good morning. Before we get started today, I had a couple of housekeeping sort of issues. We are live webcast, so if you have questions, please go up to one of the microphones and state your questions so that people who are viewing online are able to hear your questions. Also, at Amy's urging, for the very first time, we're taking questions via Twitter. So if you have a question for Amy live, use our hashtag NIHMTG, and we have someone who will ask your question of Amy. And with that, thank you for joining us today. We are so excited to have Amy here today. Before we got to that part, I wanted to tell you a little bit about the Medicine Mind the Gap lecture series for those of you who this may be your first lecture. Mind the Gap aims to explore topics that are at the intersection of research, evidence, and clinical practice, areas in which conventional wisdom may be contradicted by recent evidence. We feature topics ranging from the role of advocacy organizations in medical research and policy, to off-label drug use, to the effectiveness of continuing medical education. Through Medicine Mind the Gap, the Office of Disease Prevention hopes to engage the NIH community in thought-provoking discussions to challenge what we think we know and to think critically about our role in today's research environment. Today, we are pleased to feature Amy Berman as our guest lecturer. Ms. Berman will share her experiences from the front row of terminal illness and talk about the role of the patient in establishing the goals of care, the importance of palliation, and recommendations for healthcare policy. Today we have an opportunity to learn how an activated patient, in partnership with the healthcare team, can play a vital role in achieving the triple aim of better health, better care, and lower costs. Ms. Berman is a senior program officer with the John A. Hartford Foundation. She heads the foundation's Integrating and Improving Services grants, focusing on the development and dissemination of innovative, cost-effective models of care that improve health outcomes for older adults. Ms. Berman is the program officer responsible for a number of efforts to improve transitions of care, as well as the foundation's work to improve home health care delivery and efforts to redesign primary care to better meet the needs of those with multiple chronic diseases. Please join me in welcoming Amy Berman.
What would you do? What would you do if someone told you that you had a serious illness? If someone told you that you had a life-limiting illness? If someone told you that you had a terminal illness? This is the question that we're going to talk about today, and my goal is a simple one, but it's also a really challenging one. My goal is to take you and to put you right next to me in the front seat of the car as we drive down the road of the past 21 months experiencing terminal illness. This is not an easy task, but I'm going to try to take you along for a bumpy ride and give you the experience of understanding the decisions that I made, the understanding of why I made those decisions, and give you some perspective that might inform you as either part of the healthcare team, part of a research agenda, a policymaker, or as a person, a member of a family supporting somebody with serious illness. So welcome along for the ride. I'm honored to be here today. Thank you to the NIH. Thank you to the Office of Disease Prevention. And I am really, really honored to be here and joining you. 21 months ago, I looked pretty much the same as I do now. One thing occurred to me. I had a small red spot happen on my right breast. And it wasn't a lump. It was a very strange looking bump. And I thought I knew what it was. Many of you know that I'm also a nurse, and I had read a story about inflammatory breast cancer. I thought that was what I had, and in fact, that is what I have. What did I do? I went immediately to my primary care provider. You'd go to your primary care provider if you had something strange show up on your body, wouldn't you? Went right to the primary care provider, and I was sent for a biopsy. Well, the next thing that happened was going for a full body scan because they confirmed that I did have cancer, and they wanted to find out whether or not it spread. Probably the hardest days of my life were the period of time from finding out that I had cancer and making a decision that I wasn't yet going to tell my family, because I wanted to have a complete understanding of what was going on with me before I started telling everyone. Before I ever went for that biopsy, when I first had this spot appear and I went to my primary care physician, I did a full lit review. I looked at all the evidence about what I thought I had, and it was scary. For me, inflammatory breast cancer, reading through that material, was the scariest read that I had ever had. You should know that people who have inflammatory breast cancer, 40% live to 5 years. 40%. But for most people, they're diagnosed at either stage 3 or stage 4. It's an insidious kind of breast cancer. It's very rare. It's also the most deadly version of the disease. And inflammatory breast cancer kind of floats free and then aggregates. And at the point that it blocks the lymphatic system, it appears as that spot that sometimes people mistake as an infection, but it's not. And by the time it appears, typically it's already spread. Stage 3 or stage 4, spread far, spread wide. When I went for the scan of my body to see whether or not it had spread to a far place, it did show up. It unfortunately had spread to my lower spine. I decided that I was going to go and seek out whatever knowledge there might be around the treatment of this disease, to seek it out and to find out whether or not there were answers that might not be available in the literature. For people here on the NIH campus, they're very familiar with the fact that it takes 17 years to move research to practice. Long time. There are a lot of things that are brewing out there that offer a lot of hope, a lot of potential, a lot of possibility. And there's a lot that the regular oncologist locally may not be tuned in on. So I traveled to another oncologist who was a specialist in this rare kind of cancer. But before going, I brought my mother up to New York City. I told her what had happened. And that hot spot on my spine, that place that showed up that might be cancer, we had to find out whether it was cancer. We had to find out whether it was the same cancer. A hot spot, one of these areas that appears on a scan, could simply be, an area that's healing. I could have wrenched my back. It could have been something very minor. And knowing whether I was stage 3 or stage 4 is a big deal. For me, that means a difference in the choice of the path that I'm going to take. So imagine you're in my position and they say, we can do a bone biopsy. We can remove a piece of bone from your spine. What do you think? You don't have to do it. You could simply move ahead and say, well, we have this area that exists. I opted to go for that bone biopsy because for me this was a critical difference in the pathway that I would take. I thought it was going to hurt. I thought removing a piece of bone from the lower spine, that has to hurt. I thought, I'm going to be laid up. This is why I need my mother to come up. My mother is in her 70s. She can speed walk me into the ground. My mother is a very active, agile woman. She also plays a mean game of Scrabble. So having her with me had a lot of benefits. First, I was going to be able to tell her what's going on. But second, I would have a support system, and I'd have physical support if I needed it. I didn't know how bad I would feel after having a bone biopsy. I went with my mother. for the outpatient removal of that piece of bone from my lower spine. And you know what? It really didn't hurt. It felt like, have any of you ever had a noogie? That's what it felt like. Nothing worse than that. I felt sore. Maybe I sat down a little bit more gently for the next week. It wasn't terrible. It wasn't traumatic. And of course, the benefit was that I had my mother with me now. I had an appointment set up to go see one of these leading experts in inflammatory breast cancer. And so here I had my mother with me. I brought my mother with me to go and to travel to this distant place to get answers, to hopefully get answers. I should tell you that inflammatory breast cancer, while breast cancer is one of the more funded diseases that there is, inflammatory breast cancer remains an orphan within one of the most funded diseases. We have not made great strides. Roughly 1, maybe 2% of all people who have breast cancer have inflammatory breast cancer. It is difficult to run trials on people with inflammatory breast cancer because the numbers aren't there. It's difficult to look at diseases that affect small populations. But this is the area that is the most deadly version of the disease. What would you do? We have a disease that's the most deadly, and yet it's the least researched. That's the way it is. So we went off to see this expert to see whether he had certain answers for us. And I went with the blessing of my oncologist in New York. My oncologist packed up a set of slides for me, put them in a styrofoam container, and I was delighted to be able to share my material with this other researcher, hoping that maybe that's going to help toward getting new answers. Maybe I'm going to learn something, but maybe I'll also contribute to the research. Well, I saw this person, and I have to say, the night before going to see this particular doctor, my mother and I were trying to occupy ourselves. Of course, we were worried about how this appointment would go. Would we find any answers? So what did we do? We went out antiquing, like any good mother and daughter. We went to a street that had lots of cute little antique shops, and it was raining. It was just one of these gray days, and it was kind of that misty rain that can sneak around your umbrella and right up into whatever, and bad hair day. It's just, one of those days where the rain is everywhere. It's unavoidable. Everything that you would wear was going to be wet. And as we were walking down the street, and it was getting late, and we were going to head back to the hotel, and we were really optimistic. Despite knowing that I had inflammatory breast cancer, we were going to see the go-to person, or somebody who we thought was the go-to person. And we got a phone call. I got a phone call. And it was my oncologist in New York. And my oncologist said, it's stage 4. Up until that moment, I really assumed that there's no way that it could be stage 4. I looked in the mirror. I felt great. I looked the same. I was going and doing. I had energy. I didn't look that different than now. I may not be the best thing to look at, but I felt great. I looked myself. There's no way that I could have stage 4 cancer. And I got this phone call with my mother next to me, and I turned to her and I said, it's the worst case. It's stage 4. And we both embraced each other and started crying. We dropped our umbrellas. We were already soaked anyway. And for a few minutes, that's all we did. We just cried. And finally, I turned to her and I said, we need to take 3 deep breaths. We need to just compose ourselves. And as we took these 3 deep breaths, we started laughing because we both looked ridiculous taking 3 deep breaths. I was looking at her, she was looking at me. We looked ridiculous. And we just started giggling, laughing. it just broke the tension of the moment. And, you know, we talked about it a lot since then. Knowing that I had a very serious illness, and knowing that, according to the research, there really was no cure. Knowing all of that, the one thing that I did have was today, right? And I feel good today, and I felt good for 21 months. And I wasn't going to lose that. I wasn't going to wallow in self-pity. I wasn't going to let the cancer take away what I had. And that's a conscious decision, and it's a hard decision for a lot of people to make. But the one thing that I had was what I had. So we went the next morning to this wonderful place to see this preeminent person. And he took the slides and he gave me a physical with my mother in the room. I wanted her to be in the room. She was eager to be in the room. And he said, okay, well, here's what we're going to do. We are going to do a very intensive version of chemotherapy. From there, we're going to do a mastectomy, followed by radiation. And from there, we're going to do the most intense version of chemotherapy that you can possibly take, in hopes that we are going to hold it at bay. I looked at him and I said, well, why are we doing a mastectomy? The cancer has already spread to my lower spine. It just didn't make sense, you know? We can't remove here to here, right? He said, well, you don't want to look at the cancer, do you? That's a quote. It's an unfortunate quote. But I think even more than that, he never wanted to know what my goals were in terms of the care that I was receiving. In fact, he said, this is the approach I use with all my patients, because this is the kind of cancer that he treats. They all go into a protocol. This is what I do for all my patients. He didn't care what my goals were. He didn't really ask any questions of me. Now, I have to say, I am not trying to put down healthcare providers. Not at all. This man thinks that he is doing the very best thing possible that he can do for me. This is what he believes is the great hope. This is the best that he feels that he can do. I believe that. But the question is it? My oncologist in New York wanted to know, what do I want? What do I want out of all of this? My oncologist back in New York had talked to me before I ever went on this trip, fully encouraging me to go on the trip, telling me that if there were any answers out there, that she would be happy to do the protocol in her office, that she would consult, I could go there, whatever it is that I felt that I needed, she would support. That's what I had from that oncologist before leaving for that appointment. But I think more important, that oncologist said, what's important to you? And we talked about it. I happen to want one thing. I want good quality of life for as long as possible, and bad quality of life for as short as possible. I call it the Niagara Falls trajectory. Good, 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 drop off the cliff. That's what I want. I'm very clear about it. So if I had chosen to go the approach that was offered by this other physician, what would my trajectory have been? Well, I would have started with good quality of life, dropped it down to a bad quality of life, and according to the research, moved out to a certain length of life. Now, it's fine to drop that quality of life to later have a great longer life. That's a good plan. But the plan that was offered by this other physician to me from what I understood, did not offer a great plan. So I left that other physician, that other oncologist, the world-renowned oncologist in my particular area, and this person I know was doing what they felt was best. Again, I really have to say this. I'm not trying to put this person down. But I went back to a person who embraced what I am, what I want, my goals of care. And this really is about patient-centered care. I think we're all trying to understand, what is patient-centered care? What does it mean to include the patient in the team? Well, the more serious illness becomes, the more important it is to understand what the patient's values and goals are, because you can support very different things. Now, maybe listening to this, maybe you think I've foregone treatment. I haven't. There are approaches that are much easier on my body than what this other person was suggesting. And in fact, it's done absolutely great holding the cancer at bay. I couldn't have asked for a better outcome. I mean, it's a crapshoot, I'll be honest with you. You can choose a protocol and you may or may not, based on your own body, get the desired benefit. I'm lucky. I've had a treatment that has kept me doing beautifully for the past almost 2 years. It's 21 months now. But the point is still the same. I did not want to drop my quality down to 0 and not get a benefit from it later. That to me was a bad plan. I hope you understand how it feels to have that bad plan presented to you, and what it's like to have two different providers give you two very different perspectives. So what's important to me? That's the quality of my life. And I am very concerned about the quantity of my life too. I'll be honest with you. I'm not looking to shorten my life. Some of you may have read an article in the New England Journal of Medicine on palliative care. I'm going to tell you a little bit about palliative care, but palliative care that supports people's quality of life, that really focuses on their pain and focuses on their symptoms and focuses on their function and the families and coordination, all of those good things. Palliative care actually helped people in clinical trials live longer. Not live shorter, live longer. You know, when we think about what's going on in this country, we have an age wave. I think everybody's aware of it. If you're not, you know, the demographic shift is we're going from 35 million age 65 plus to 70 million. We've got a doubling of older adults going on in this country. I'm young. I'm not that young. I've got my AARP card. So I turned 53 in October. But most of the people who have cancer, 63% of cancer patients, are older adults. And what's going on in this country, this age wave, it's not just a doubling of older adults. It's not just a doubling of, you know, the incidence of cancer. But you have to understand that as 10,000 people turn 65 each day, that they also are skewing older. The fastest growing group is 85 plus. Now, if cancer is primarily a disease of aging, you have to understand that cancer is going to be exploding. It already is. It is a devastating thing to people, but it is also a societal issue that we have to grapple with. And even more than that, in an older adult population, you have cancer not on a blank canvas, but on a canvas that already has typically multiple chronic disease. So things are going to get a lot more complicated. The reason that I say this is because people are going to have to think about what's the goal of care. What is the goal of care? One of my parents' dear friends was diagnosed about 2 weeks ago with bladder cancer. He's 85 years old. Marty is 85 years old, a very, very active, vigorous man, but he has multiple health issues going on. And now he has stage 4 bladder cancer on top of that. And he has to make decisions. And I'll tell you, he's decided to throw everything at the disease. I'm telling you this because people may not be fully informed that having treatment may have a benefit, but it may also have a downside. People who have these kinds of treatments have to grapple with the physical ailments associated with those treatments. It is debilitating. And for older adults with multiple chronic disease, it may be much more debilitating. I don't know what will happen with Marty, but it is possible that this will shorten his life as opposed to lengthen it. And the reality is he was recruited into a protocol and he may not understand all of the options that might have been available to him. These are very, very complex conversations. People need to know not only what it's going to do to the disease, but what it's going to do to the person, to the family, to the pocketbook. People have to have a full understanding of what the other choices are and what that's going to do to them, to the disease, to the pocketbook. We have to get real about this. These are complex issues. You know how I feel. Every one of you could serve as my healthcare proxy now. I want that Niagara Falls trajectory. Don't push for a longer length of time if it's a bad time. I don't want that. I want a good time for as long as possible. And I've chosen a pathway that hopefully will support that for as long as possible. So with that, I'd like to talk about palliative care. Palliative care, as I said before, is treating pain and symptoms. That's a good thing. Palliative care is not the same as end-of-life care. It's not the same as hospice. Palliative care focuses on keeping that person with as great a function as possible. So there's a lot of fear about palliative care. People don't know what it is. I don't understand this. If you were to think about waging war on cancer, cancer is a disease that's waging war on your body. Chemotherapy, that's chemical warfare. Radiation, atomic weapons, right? Palliation, that's the peacekeeping force. When you are going for active treatment and you're in a curative mode, palliative care can help control the symptoms related to that treatment that you may ultimately get better from. Palliative care is not for end of life. It may be offered at end of life. Palliative care can be offered with any course of treatment, any direction. And yet, it's not. People don't know to ask for palliative care. When people undergo chemotherapy and they have nausea, vomiting, chills, aches deep in their bones, chemo brain, all of the debilitating pain that they may have from the treatment itself, not from the cancer, but from the treatment itself. Palliative care is their best friend, but it's the best friend that they don't know about. It should be begun at the beginning of disease. When you have a serious illness that is going to cause pain and symptoms, at the very beginning, whether you are undergoing a curative course of treatment or whether you are progressing toward end of life and you are not on a curative path. If you have chronic disease that is debilitating, palliative care should be the partner in your care from the onset. But it's not. It is for some, but it's not for all. It's called in late in the game, if at all, for some. And it should be there for all. Again, if you were to think about it, this is the peacekeeping force as you have a war being waged on your body. Palliative care needs to be there. It needs to be widely offered. At end of life, which is different than palliative care, at the end of life, there are a whole host of things that you have to think about. Now you look at me, am I at the end of life? Not today. You know, I'm living, I'm not dying today. But tomorrow might be my last day. And I do have to say that I have gotten my house in order, so to speak. I have a healthcare proxy. People know my wishes. I have advanced directives. Many people are offered the opportunity when they have serious illness, when they're in a nursing home, they are offered the opportunity to complete advanced directives. But they don't understand really what that means. And for many people, it means signing a form saying, do not resuscitate. Well, take a look at me, for example. Okay, stage 4, 11% of people with stage 4 inflammatory breast cancer live to 5 years. I've gone for almost 2. So you have some sense that it's highly likely that I will at some point in the relatively near future end my life. But I'm not going to die up here unless I'm a really bad speaker. Well, so it's very important to have those advanced directives. But if I were to be asked, do you want to fill out a do not resuscitate order, what do you think I would say today? Everybody here is shaking their head no. And that's right. I have no intention of filling out a do not resuscitate order today. I want to continue living because right now, as I said, I have good quality of life. I want to have that good quality of life for as long as possible, then drop off the cliff. Niagara Falls trajectory. Do not resuscitate order now wouldn't make any sense. But I need to make it very clear to my healthcare team, to my family, to whomever is my healthcare proxy, what it is that I do want and when they should be initiating a change. Well, what that means is that I have to have ongoing conversation about my goals because they're going to change, because my health is going to change. The way that I feel is going to change. And at some point, I am going to want that do not resuscitate order. For now, what I've done is had great conversation with my mother, who's my proxy. She's also my best friend. She knows me very, very well, and I'm also her proxy. I know what she would want. So right now, we're clear. I feel I'm covered. Should I make a sharp downturn or, head south to Albuquerque, she knows what she would do for me. And I'm very comfortable with that. But there are other kinds of forms that people can fill out at end of life that are not just the advanced directive. Some of you may have heard of POLST, Physician Orders for Life-Sustaining Treatment, or another form called MOLST. In New York, they call it MOLST, Medical Orders for Life-Sustaining Treatment. This is a guided conversation. It's a process where people gain an understanding, a perspective of what you want, and convert it into an order that the healthcare team must follow. This is much more nuanced than saying, do not resuscitate me. Do I want to go on a ventilator? Do I want invasive things done when I no longer have that quality of life? Do I want to have antibiotics? In my case, when I no longer have good quality of life, I can tell you now, I've already had discussion about this, I don't want those antibiotics. I don't. I'm very willing to take that course because that supports the trajectory of my health. For as long as possible, I would like to support good health. When I no longer have good health, there are a range of conversations that one should have with their family and with their providers to understand what care should look like. So this is really important. So we've talked about palliation, which can be with a treatment that's going to get a great outcome, but at the very beginning you want to have palliative care hand in hand with treatment, no matter what the goals of that treatment are. We've talked about end-of-life care. I'd like to touch on a little bit on hospice. Hospice in this country is typically used in the final days or weeks of life. Too often I hear about people who are told to go on to hospice or offered the opportunity to go into hospice, which really focuses on comfort. It's not focused on cure. It's when you know that you are at end of life, you really want to focus in on comfort. And it gives a whole range of services from palliative care, spiritual care, a whole range of supports and services for the person and their family. But unfortunately, while the hospice benefit was set up to help people in the final months, it typically is brought in the final days, and people are not really getting the benefit of hospice care. I don't know what my trajectory is going to look like. I don't know whether I'm going to have a long, bad period at the end, no matter what treatment choices are made, or whether I will get that short, bad period of time. But I can tell you that if there's any planning and intention to this, it will be that I will go on to hospice when I can go on to hospice. I don't need hospice today. I can do the jig. I climbed the Great Wall of China in June. I'm not ready for hospice. I have a lot more in me. And I guess this is something that we all need to think about, whether you're part of a research team, whether you're part of a healthcare team, whether you're a policymaker, or whether you're a patient or a family. And I actually prefer people rather than patients. We're people. Patients, it just sounds like we're separate, we're over there. We need to understand end-of-life care and embrace it in this country. Now, this may sound very radical, but we haven't changed the death rate in this country. It is still hovering at 100%. Everybody's going to die. We all know that. I mean, nobody wants to talk about it. We actually don't want to have conversations around serious illness or death in this country. I mean, we're scared of it. It's a toxic conversation, right? But 2.4 million people die in this country every year. That makes it a common occurrence, and yet the conversations are uncommon. It doesn't make sense. There's been research lately saying that providers, physicians, would typically choose a different course of treatment for themselves than they choose for their patients. Does this surprise anyone? Why is that? Are they scared? Is it difficult to approach these conversations? Do they not want to tamper with someone's hope? Are they trying to do good and benefit the person? I think people are well-intentioned. I am not somebody who believes that people are trying to avoid these conversations. I think they don't know how to have these conversations. I think that there is a certain amount of fear about it, a lack of insight to it. But I would just say I'm one of these people. And if I can be a voice for all of this, let me just say we need to be invited into the conversation. We are not only part of the team, we are the CEO. We are the center. Everything is built around our health, around our N of one. It's all about us and our outcome at the end of the day. And people who are well informed make better decisions, better health, better care, and better cost. They make better decisions. There was some work done at Mass General Hospital showing videotapes of what it looks like to be in an ICU. Nothing jarring, just a picture of what it's like to be in the ICU versus what it's like to have end-of-life care at home. And it was shown to people who were critically ill, who were making these decisions. Now, they had already made the decision what they wanted to do. And they had a 100% change of mind when they had a real understanding of what those decisions meant. maybe there are other ways that we can give people insights. And let me just say, there are no wrong decisions. People don't have to do what I'm doing. I don't believe that. There are no wrong decisions. There are only informed decisions. It's that lack of information that is at the heart of the problem. And I think more people might be willing to say, you know what? Maybe I don't want to throw everything at it if I'm stage 4. For some disease processes, that may actually be the right thing to do. I would have gone big if I had stage 3 cancer, because the likelihood would have been that I would have lived a longer, better life doing that. But all of the research suggests that it's not true if I'm stage 4. That's my take on the information. I'm very comfortable with what I've done based on this information. So these are very, very complex and challenging conversations to have. I just want you to know that in the 21 months, I've felt great. I've been writing about this. For those of you on social media, you can follow conversations that we're having. Well, you can follow today's conversation on NIH Prevents. You should be following on Twitter. You can follow me on J. Hartfound. I work for the Hartford Foundation. And I have a personal Twitter, which is Notes on Nursing. And today, I welcome you to jump into the Twitter conversation. The hashtag, again, is NIH MtG, Mind the Gap. Today, we're really talking about minding a gap that's really pretty huge, but it's going to get a lot bigger. We have a societal shift going on. Let me just say also, we have an issue going on around hope and communication. The term people use today around serious illness is called advanced illness. Has anybody ever heard that term before, advanced illness? That is the generally accepted term. Would your mother know to get her things in order if she had advanced illness? Advanced illness? Would that tell you that this was terminal? Terminal is a word that people don't want to use. Providers no longer use it. I think it's exquisitely clear. We don't know whether someone will live or die. We don't know. We don't have all the answers. But providers have some general understanding of what a disease is and what the likely outcomes are going to be and what the likely choices are and what they may do for you. And I think we have to get much more clear on the language we use. Now, I want to talk for a minute about hope. Hope is protective. If you have hope, if you believe that you can get better, if you think in a positive way, that's protective to you. Obviously, despair is the complete opposite. It attacks the immune system. It really puts you at higher risk for everything. But hope can also be used as a barrier. A barrier. If a provider does not want to give you the real information that you need because of their fear that they're going to interfere with your hope, then you don't have the opportunity to make these kinds of choices. I wish I had a medical ethicist standing next to me to weigh in here. It would be an interesting debate, but all of those things that are protective can also serve as barriers. And so we have to think about how to get clear. In a cultural context, since we have, a very diverse population becoming increasingly diverse, we think about different groups of people that may or may not want to know. In my area, where I go, there's a very large community that's from South China. And the culture there says you don't tell somebody how serious their illness is. You simply give them a treatment and you talk to their children. That's culturally accepted in that community. But cultural acceptance can really lead us also, this cultural competence, can lead us to not invite that individual, knowing that not everybody is the same as an entire community, to not invite them and ask the question, how much do you want to know? Not how much does your community want to know, how much do you want to know? And I wonder for many of the people that I see when I go for my monthly infusion for my bones, I wonder as I see people go through these infusions in their 80s and even 90s, I wonder how many of them were never invited. How many of them were never asked, how much would you like to know? Not diving in and saying, I'm going to tell you everything, because that may not be something that they want to know. But how many people are invited? How many people are asked? Now, it's really important to think about the fact that today we really don't have patient-centered care. Some of us do, but all of us do not. And if we look at the healthcare record, I challenge any of you to find a patient's goal in that medical record, in the electronic medical record. Have any of you ever seen the patient's goal in a way that is shared information amongst members of the healthcare team? It might be a small note. It might be buried. The diagnosis, front and center. Treatment, front and center. What's the patient's goal? Dig for it. You might find it. For most, you probably won't. And if you do, that patient's goal might be in healthcare ease. It's not going to be their language. What are they really looking to do? Walk their daughter down the aisle? See their child graduate? What's their goal? I'd like to see Niagara Falls trajectory in my medical record. I'm not sure. I have a feeling that my doctor may have actually written that in. She's just been magnificent. I have to say I'm very, very lucky. She puts up with me really, really well. But we need to think about this in terms of the way that we establish care. Right now, in terms of the systems, the larger healthcare systems, this is not what we think about. We don't think about the patient's goals of care. Now again, if you were to look at palliative care, which is focused on your function, your quality of life, it can be used along with treatment that is for cure, treatment that is toward end of life, any direction in complex illness, palliative care. Palliative care does care about your goals of care. And if you were to look at that palliative care provider's chart, you would find their goal of care. You would find what they're trying to accomplish, what they're trying to work on. It's a very different way of thinking, and again, one of my recommendations would be that palliative care be much more widely available. Today, it is, generally speaking, in large teaching hospitals. It's in the larger hospitals. It is expanding into smaller hospitals. But fortunately, a lot of people aren't in hospitals. They're in the home. And how do they get palliative care when they're not in the hospital? Do we want to wait till they get to the hospital? I think we have a lot of questions about how we are structuring the care to get the best possible outcomes. So today, I hope that I've given you some sense of what it's like to be in the front row for 21 months and a little bit of perspective, why I make the choices that I'm making. And perhaps this informs your research, how you recruit patients in, how you keep them in a protocol, and perhaps they may be changing and may have other needs that may go unaddressed. How people communicate the options, the needs of families, and for policymakers, how they're going to grapple with this rising tide of complex illness and then superimposed on that very serious illness that if we don't get it right, and if we don't really have conversations openly about those choices, people aren't going to have the option of choosing what I chose. If we look back 21 months ago, I came to a fork in the road. 2 paths. If I had gone down the other path and I was here talking in front of you 21 months later, I'd be sounding different. I'd be looking different. Maybe with chemo brain, I might be thinking differently. Maybe I already think that way, who knows. But, you know, I would have been a different person. I wouldn't have been able to work, enjoy my family, travel, do all the silly, wonderful things that I get to do, continue to support people in the healthcare field. I wouldn't be the same person. I wouldn't have had the same 21 months. And it has been a blessing to me to be able to make the choices that I make. I take 1 pill at night before I go to bed. It's something that keeps my hormones in the basement because my kind of cancer grows in the presence of those hormones. I take an infusion once a month for my bones. I have a very low impact kind of an experience. It's not difficult for me to go through. I feel good. I continue to do. I'm enjoying every day the same as I always did, not different. If I had made the other choices, it would have been a very different path. I want you to think about this in the context of what you are suggesting to the people that you care for, what you look at in terms of the research that you do. We have to answer these kinds of questions, not just for the numbers of people today, but the growing population that are going to be confronting these issues. These are huge issues. They are exploding on the scene. And it's not just cancer. This is the explosion of aging, and we have to think at the very end, what is the goal of care? When you have a person who might have dementia, who has cancer, what's the goal of care? What's their goal of care? Not what's your goal of care. What's their goal of care? What's the family's goal of care? We have to be able to have conversations. We want patient-centered care? Well, we're not going to get that unless we ask the patient. That's the most important thing I can tell you today. There are no wrong decisions. There are only informed decisions. I'd like to welcome questions and remind you that you have to come up to the speaker so the folks who are watching this on webcast can hear your questions. And for those who are interested in tweeting in your questions from the Twittersphere, go Twitter. Use hashtag NIH, MtG, Mind the Gap, NIH, Mind the Gap. And we will also bring your questions to the microphone so everybody can hear them. So I welcome any questions.
Hi, Amy. Jody Engel with the Office of Disease Prevention. First of all, as far as the Twitter goes, shocker, I'm having technical difficulties. So I apologize if anyone is sending in their questions using that hashtag. I would recommend that they send a tweet to Notes on Nursing. If you'll allow me to speak for you, Amy will respond to your tweet. On a personal note, I salute you and your strength inspires me. So thank you so much for today. I do have one question for you. Have you talked to the healthcare providers, and specifically the one who you went so far away to visit, to explain how his point of view did not include what you're looking for, to try to help his view in the future for his future patients?
I have not spoken to that person. I went, it was a brief visit, probably 15 minutes from start to finish. And I felt that this person had a perspective and had a protocol. And so no, I have not had conversation with this person. And again, I do not in any way want to denigrate any member of the healthcare team. People are doing what they feel is the best possible thing they can do. But I have not had any real conversation with this person.
Hello, Amy. Thank you very much. Thank you very much for being here. I'm Rosalind Nat. I'm at the end of, in the 11th of 12 weeks of being an intern, a chaplaincy intern here. And I have to say that the most rewarding part of my week has been the morning that I spend with the Pain and Palliative Care group. I heard you mention spiritual care in hospice, but I would like to hear you speak to spiritual care actually from the very beginning, from the beginning of palliative care.
Thank you for that. We are whole people, and that whole person needs to be supported. I just want to say that I often think about the words of William Osler, who's the father of modern medicine. He says the good physician treats the disease, the great physician treats the person who has the disease. Well, it takes an entire team to be able to help support that individual. And we are not just supporting a treatment. We are supporting that person, their family, and their spirituality. And people, have many different perspectives on this. But again, it is an invitation that needs to occur at the beginning of serious illness to make sure that the person has spiritual support. That if this is something that is a part of their life, that they engage around it actively and that they get the kind of support that they need that fits with their belief system. This is really, really important. I mean, we know that people who feel that they're supported and families that feel that they're supported through their beliefs in a higher power, a higher being, God, that this is helpful and protective to them, that it helps them through a very difficult time. And, in my case, I do have a spiritual side, and I do draw upon that. I've had thoughts and prayers also sent from all over the country, and people have asked whether I welcome that. I can tell you from a wide range of faiths, including being written on the wall in the Mormon Church. I've had, all kinds of people offer it. For me personally, I believe that all voices go to that same power. So for me, I'm glad to have a chorus. And I do draw on that. But I think it's very important from the very beginning to be able to invite and ask and engage around your spirituality as another means of supporting your wellness, because that is one part that can be seriously shaken by the experience of having serious illness. So I really thank you for that question.
Hi, Amy. I'm Neeraj Arora from the National Cancer Institute, and I'm also a long-term cancer survivor. So first of all, on behalf of all of us who have ever been diagnosed with cancer, I want to really thank you for your wisdom and your courage. And I hope you stay on the good part of Niagara Falls for a long, long time. And when that fall comes, it's as gentle as possible. I have one question for you. I lead a program of research at NCI in the area of patient-centered communication. And the goal is to improve and facilitate better patient-centered communication between patients and clinicians. So if there's one advice you would like to give us as to what would be one or two key areas that you would like to see us focusing our research on, what would that be?
Well, in terms of the communication, I guess one of my concerns is that communication oftentimes is thought about as helping people adhere to a provider-centric notion. And for me, it was really important to think about how the communication early on could inform the path. So I'm increasingly concerned that, as we think about motivational interviewing, teach back, other forms of excellent communication, that we have to think about whether or not we're using them in ways that are coercive, ways that are informing what the healthcare provider wants someone to do, and what's the degree to which that provider elicits what the person's goals, values are around the care that they want to receive, and how is care formed around that. So that's a real challenge for you. I will say that, there are measures like the patient activation measure, which is very important in determining how activated we are towards supporting our own health. And we want people to be very active participants in their health, correct? But you can think about that patient activation as being kind of gas in the gas tank. How much energy do we have toward moving forward in the right direction? But if you can imagine gas in that gas tank, and it's a cab, and you say, go to the airport, we want to get better, go over there, and they take it to Dulles instead of National. What are we doing? So at some point, the conversation still has to occur before we kind of take these paths. And that's the piece that I don't see. I see a lot of process about engaging people in the plan and activating them. And I'd like to see more of that. I'm not running from that. But there's something perhaps more upstream and more central about what is that path? What is it that that person wants? So the very notion of patient-centered care has to be predicated on knowing what that patient wants, and how you're going to get that through communication. I just saw an excellent blog written, it was tweeted by Kevin, MD, on 5 things the patient should ask their doctor, that really, for me, summed up very nicely a perspective on the kinds of information that I actually needed at the beginning of care. So it was a great dose of information on what that communication needs to look like and consider. You may want to look at that. Yes.
Thanks, this was great. Ann Berger, I run the Pain and Palliative Care service here. I'm also a cancer survivor and have had a rare cardiac condition and have significant disability from the cardiac condition. And because it's rare, when you have rare things, you have problems in the medical system, as you know. And it's interesting when you said goals of care, because the biggest problems we have in palliative care is goals of care. It's not discussed at all. So just this week, we had multiple problems with lack of discussion of goals of care on our service, and patients running into big problems because lack of discussion of goals of care. But I guess I never thought of it as lack of discussion of goals of care at all times. And that's really what this is about. I myself have had huge problems with medical people because lack of discussion of goals of care, and avoid doctors like the plague because there's no discussion of what I really came in for. I come in for one thing because I have a problem or a symptom, and they go off on some other planet, some differential diagnosis that they think, and it has nothing to do with why I came in for, and, they're not really helping me. And then I, at the end of the day, am never helped. And so I go, I'm not going back there. Then you ask, well, did you ever go and tell them? And in fact, I want to write an article about this through the Undiagnosed Disease Program and have spoken to Dr. Gall about this. And, you ask, well, have you gone back to these people? Because I have gone so far as to say, well, these doctors are idiots. But no, I have not. In some of the finer places, best hospitals in the area here, but no, I've not gone back because as a patient, you are scared to go back because with a rare illness, will I need these hospitals? Yes, I will need these hospitals. So I can't go back as a patient because I will have a red mark next to my name. As a nurse, and I'm a nurse, and as a physician, I know what the medical system is like. So no, you don't go back and complain. You just go, oh, well, that's the way the medical system is. But the real problem here is there's no communication with our medical team. They talk, and that's what we all do. They talk, and and everybody's in a box. Nobody thinks outside of any box. And nobody listens to the goals of the patient and what the patient wants at all. And it's not just end of life. We see it at end of life, and so people all end up on vents, but that's the least of it. It's all through life and through the disease trajectory. That's what this is all about.
So I'm sorry for what you're going through, and I'm sorry for your experiences.
So-
I do have to say that there are some providers who are exquisitely tuned in to the needs of their patients, to the needs of the people
Hard
that
to find.
they work with. Well, it
Yeah.
is a challenge, and
Yeah.
it's a challenge because this is an increasingly specialized environment.
Right.
And they really are trained to focus on, being body partologists.
Right.
Not peopleologists. And that's a challenge. That's a real challenge to have somebody tune in on, what are you hoping to be able to do?
Right.
Not what are you hoping your heart is going to be able to do? What are you hoping to
Right.
be able to do?
Right.
How are you hoping to be able to function in a way that maybe you don't function now?
Right.
And to make sure that the whole team is on that page, that is a challenge.
Right.
I don't put this all on people, on patients. I really think that this
Right.
is the opportunity, the biggest opportunity for patients to be able to partner with their providers. And I
Right.
think that there is a cultural shift that is beginning to happen and will increasingly need to happen. It will be necessitated. If we are ever going to meet the triple aim, better health, better care, lower cost, it requires both people to work together toward a goal. And the
Right.
only way you'll be activated to follow the plan, is
Right.
if you're helping to make that plan. So I hope that by sharing your story and perhaps writing about it, you will also help inform others about this. There aren't that many people who talk about these kinds of experiences and how important it is to have this communication. So I say hats off to you.
Well, thanks. The other thing, the advanced directives, that I would urge is actually extremely important to get started early for everybody. We don't know whether we're ill or we're not ill, what's going to happen.
That's right.
And anyone can get ill at any day, even if you're feeling fine one day. And so it's a type of thing that I think everybody needs to think through, what if and what would I like my life to look like and what would I want? And so you really do need to communicate with family or friends or whoever you'd want to be there for you, to speak up for you, so that people know, people around you know what you'd want. And too many people, including many healthcare professionals, don't have any kind of advanced directives. So, I would urge people to think about that and do that.
So you should know that 50% of people at the end of life are unable to make some or all of their healthcare decisions. 50%. And they typically do not have advanced directives. So advanced directives are not the rule. They are, unfortunately, not as common as we would like to see it. It's an increasingly important aspect. But I have to say, the advanced directive goes hand in hand with having conversation with, let's say, the healthcare proxy. So I told you, for me, it's my mother. My mother really needs to know what those decisions should look like. We have to have a whole range of conversation. There's a writer, Pulitzer Prize-winning writer named Ellen Goodman. She used to write for the Boston Globe and I believe also for Newsweek. I hope I'm getting that right. And she's doing some work called the Conversation Project. that's really about fostering those conversations in the family. And it has to start in the family. I think of this as, my ability to have these exquisitely clear conversations within my family as a way of supporting the very great difficulty that they're going to undergo when they have to make those decisions, because then it's not their decision. They're supporting my decision. I've taken a burden from them. How are we going to proceed? She's really not doing well. What are we going to do? She told me this is what she'd want. It takes a burden from them. I become the voice in the back of their head. They know they're doing the right thing. Even if it's not the thing that they would want to do for themselves, they know what I want. That's a huge support to a family that's going through a very difficult time. So it's not just the advanced directives. It's also about those conversations that need to occur so that the family knows, how do I really act upon this? It's not just the right to act upon it. Yes.
Amy, good morning, and thank you so much. I'm Rebecca Kirch from the American Cancer Society, and what we hear all the time from our patients, from our families, and even from health professionals is give us the words to use to give the care that we need. And we're so grateful for you giving this talk today and the Health Affairs article and every opportunity we have to give our constituency the words to use. And I'm also proud and pleased, and the timing's impeccable, because in the last 2 weeks, the American Cancer Society's advocacy affiliate has introduced some federal legislation to promote earlier palliative care. And some of you may have seen the beautiful ads, I'm biased, but they are beautiful, promoting the importance of palliative care as something that treats the person rather than the disease. And they're in the New York Times and in all the major Hill publications right now, and we're hoping to turn this from a policymaker educational opportunity to a true quality of life movement. And I think hitting on the points you talked about today is sort of the fundamental premise of this quality of life campaign. What's important to you? And it stems not around end of life. That's too late for the conversation to begin, and advanced directives are important at a time when they're appropriate. But it's really about finding the quality of life formula and get what gives people their joy, that Niagara Falls trajectory, which is something our volunteers are going to be taking to Capitol Hill next month for our lobby day. And I would love it if you were in the various congressional rooms next month with our patients, our caregivers, our families, and the professionals who come for our lobby day. What would be your number one ask of the policymakers as you sat in those meetings to talk from the perspective that you're sharing with the world now?
I would say two things. One, that patients need to be well informed, so conversations need to occur, and those conversations need to be paid for. Second, palliative care should begin at the beginning of serious illness, not as something that is an intervention at the end. It is the peacekeeper. It is the thing that will keep us as well as possible for as long as possible. It is central to that disease process. It is central to us as people. And we really are not fighting a disease. We're fighting for ourselves as people.
Thank you very much.
I really appreciate what you're doing.
Come on up. We have a question for you on Twitter.
Yay.
Palliative care is not included in the top 25 questions to be addressed by the National Cancer Institute. What can we do to get this on their agenda?
So as somebody who's not on the National Cancer Institute, but gets to be here supported, I would just encourage the National Cancer Institute to carefully look at their strategy in the face of an aging nation where this is going to become just an enormous issue. It is already an enormous issue, and it needs to be part of the agenda. I think, it's a very interesting thing. The research agenda has been fractured. Does ARC handle health services research? Does NCI handle, finding cures? We really need to look at things differently. I think, again, I am not within the federal government. I work for a healthcare foundation. But I've seen a remarkable change in the Beltway within the past several years where Health and Human Services has looked across entities, how do we work together to impact the most important questions? You know, ARC has small funding. ARC right now is under attack for its small funding. But even so, this is a central point that should be clearly identified within the National Cancer Institute's agenda. It's something that is going to be clearly a central part of the healthcare cost, care, and quality debate. What is the kind of care that is most supportive to the best possible outcomes? And, you know, if this is what the research shows, then we have to figure out how to integrate it at the beginning of care. And that's something that we need to see. Is this the most effective approach? What are those effective approaches? How do they look? And how do we spread that? So yes, thank you for that. Thank you from the Twitter sphere.
I'm Deborah Langer from the Office of Disease Prevention, and I wondered if you knew whether or not any of the medical schools are starting to integrate this kind of lesson to the up-and-coming generations of physicians. You know, you hear people talking often about doing birthing plans, and that's sort of become integrated into your conversation with your OB. So I wonder if this being sort of a new and a little obviously sensitive topic is something that they could start integrating into the role of education at the medical schools.
I love that analogy. I hope you don't mind. I'm going to borrow it shamelessly. But you're right. I mean, this is how we have to think about the plan. You know, it is like a birthing plan. What is going to be the longer-term plan about what that care should look like? And there are some places that are certainly integrating this into the kind of education that they're providing. I think we are challenged around team care in general. This is an area where I think you may know that HRSA has done a request for proposals and will be doing some larger work along with funders to support team care, and the John A. Hartford Foundation and Macy Foundation and others are looking at this as a very important issue. But this is really integrating all of the components in the education. You know, it becomes an unnatural act. If you train people in silos and then they go and work together, we're expecting something that we really haven't fostered. So how do you integrate palliative care into the process is really important. I have gone to some universities to give talks. I know that there are people who are very interested in this. Integration into the curriculum is a challenging thing. I don't know how many of you come from an academia, but making any change in the curriculum, you're talking about holy grails. It's very, very difficult to make inroads. But I think people are thinking about, what is the right way to focus people and give people perspective, and to give people the communication skills that they need, and to foster the right kinds of outcomes. I think there are a new set of questions that people are grappling with today in practice, and it is definitely feeding up to the academic environment because people are not prepared for them.
Hi, I'm Paris Watson with the Office of Disease Prevention. I know that your mom is your healthcare proxy, and you've talked a lot about that relationship. How are those conversations with your children? That's a much different dynamic.
Yes. Well, I told my children at the very beginning, once I knew exactly what was going on with me. So once I knew that I was stage 4, when I came back from that other doctor, I sat down with each of my children separately. They're both young adults, so they aren't at home, or they aren't at home all the time, and so I had them at different occasions to talk to them. My daughter was very quiet, and as I was telling her, this wave of emotion started taking hold of her, and over the course of time, she's read every blog that I've written. She read the article in the Washington Post that was excerpt from the Health Affairs piece. We talk quite a bit, and my son as well. My daughter told me, I asked her, what do you think about the decisions that I'm making? And she said, it's a no-brainer. anybody would do this. And I know that that's not true, but that was her way of saying that this is the right decision. She's supportive of the decision. My son was different. My son cried every time I would broach it, didn't really want to discuss it, had a very, very hard time, kind of taking this in. He's a quieter person. My daughter, she'll talk through anything. My son, he takes it in, and he really had a very hard time expressing himself. And it was probably 8 months into it that, after having all of these discussions, because I did a lot of push strategies. I couldn't find the right pull strategies to kind of elicit responses. And mind you, I've offered them all kinds of help and support, and my family, is very helpful and supportive to them. I've offered them professional support, and none of them wanted to take advantage of that. But about 8 months into it, my son said to me, I know you're doing the right thing. Up until that moment, I really thought that he was not at peace with what I was doing. And that really concerned me, because if he thought that I'm trying to shorten my life, I'm not. I mean, the research actually shows that choosing the pathway I'm choosing, I may actually, live longer and better, that I'll get, a double benefit. But I think it was hard to know what was going on in his head. And as I said, anytime that I would broach it, he would just, he'd look at me, and the tears would be rolling down his face. So my daughter, as I said, we've had many, many open conversations about it. And maybe, 6 months ago, I had a conversation with my daughter asking her if she had a preference about where I'm buried. And, anybody can make plans, pre-need plans, but certainly if you have a stage 4 diagnosis, it's cheaper. It will leave more to the kids if I can do pre-need. And, I'm pragmatic about these things. I want to get as much out of the way so that I don't burden them with those things. My parents are down in Florida, and they would like me to be buried with them. My father feels strongly that if, one of them dies before the other, that they would like to be able to visit on a regular basis, to visit, the grave. So I'm in New York. And I asked my daughter first, if she had thoughts about this. And this is a person who, we've had chirpy conversations, smiley conversations. We've talked about kind of the good, the bad, the ugly, smiled our way through it. Well, all of a sudden, my daughter looked just like my son. I mean, she went from being somebody who could be composed talking about anything, because, we've talked about this stuff now for, a year and a half, to waterworks. She just looked at me like all of a sudden it hit her that this is real. And I realized I am being an insensitive boob. I just was not, being very thoughtful in how I approached it with her. So we talked it all through, and she had strong feelings that I'd be buried in New York because she would want to be able to go and visit. So it's surprising. I think that we're in good shape, and they've been doing well. And then if I touch upon things just, to prepare, all of a sudden I realize how very raw it is. The funny thing is that at the beginning of all of this, 21 months ago, if you would talk to me about any of this, it was talking about my children that would make me turn into waterworks. Anything else I could talk about with a straight face. But talking about my kids, that was my biggest fear. Like, will my kids be okay? They're my children. And they're not fully formed. They're young adults, and they're doing beautifully, and we have a great family support. But my biggest concern was for them. So today, I can honestly say I feel very good about where they are, and they're very supportive. And at least now I know they're very supportive. It would have been a lot more challenging if one felt one way and another felt another way. I do have to say, because I blog about this, probably one of the most touching letters I ever got was from a woman who said that her mother had died years before, and she had battled depression. She and her sister, who were probably in their 40s, had battled depression for years about their mother's death from cancer. And the thing that had bothered this woman was that her mother had not opted to aggressively treat toward cure the cancer. The mother had stage 4 cancer, and she opted instead to go with a less aggressive approach and to focus on other things that were supportive of her having a good quality of life. And this woman had read the Washington Post piece, and she said she never understood why her mother was doing what she did. And she said she had time with her mother. They took trips together, they had talks together, and in all those years she thought that the daughter thought she had failed because she had not convinced her mother to fight. And at the end of it, she realized her mother was fighting, but she was fighting for time with her daughters.
I'm Paul Coates, and I'm acting director of the Office of Disease Prevention. I had 3 things that I wanted to do. One was to thank our co-sponsors for this splendid seminar, the Office of Research on Women's Health and the National Center for Complementary and Alternative Medicine. I also wanted to thank people for their very thoughtful and sometimes courageous questions. And then the third thing I wanted to do was to thank you. You informed, you educated, you challenged, and you touched our hearts. Thank you.
Thank you so much.